be viewed by other people at a later date. We would appreciate any engagement and comments from you via the chat function, and you'll see the chat function at the bottom of your screen. If you click on it, and it will open up a column on the right of your screen. There will be a break after 20 minutes for you to for us to be able to respond to any of the questions that you've asked on the chat function, as well as share any experiences of undertaking research in public health. And there'll also be the opportunity to ask questions at the end. So without further ado, it gives me great pleasure to welcome Lindsay to kick off with her talk.
Thank you very much, Fahana. That's great. I will now share my screen. Lovely. I'm just going to, great. Oops. Thank you very much. Now, this is the first webinar I've ever done, so I do apologise if it's not very slick, but I will try my best. The point of this is to try and help RDS advisors largely to support research that is being their aspirations to do in local government public health, because I'm sure we're all familiar with some of the challenges, but what we're trying to do is help you all understand a bit more about how it all works, so that you have a better comprehension of the context that public health people are working in at the moment. Just to start off, as Fana said, I'm a public health specialist, and I've been working I worked in the NHS for, well, 20 years, until about 5 years ago, in public health in a range of organisations. I always had a foot in academia, which is why I'm in academia now as well. I was a consultant in public health for Wandsworth PCT when they existed, and we asked you who you were, and you replied. Those of you who responded, which was a very large proportion of you, thank you very much. Most of you were RDS advisors, and most of you had got experience of employment in the NHS, local government, or Public Health England. And the reason I asked that question was to just get a feel for whether, you know, that there were a lot of very, very pure researchers amongst you who hadn't actually worked, you know, in any sort of public health practitioner type of role. Now, I'm not saying you would have been public health practitioners, but, you know, in a role where it's delivering services rather than being an academic. It was very clear that quite a lot of you had quite good confidence to know what public health was, but less confidence about how it works now in the NHS. And what you wanted to know, most of you who responded wanted to know a lot more about the context and motivations among public health people aspiring to do research in public health, and the opportunities for them. A few of you highlighted were at a sort of, I think, at a different level, and possibly wanting other things, which is more about how public health research funding stream makes its decisions, how it works, and how we can do more fundable applications. The second of those I'm going to address less, because I have to say, I don't think any of us knows fully, but I do think, you know, the answer to that question, because there are some very structural challenges that we have to deal with, which I'll go into a bit later. So I'm going to focus mainly on the context and, you know, what public health is, what how it works in this country, and who is the workforce, who are these people that you're dealing with. And then what we'll do is, what I'd like to do is I will talk for about 20 minutes, and then please do contribute to the chat as we go along, and we're not going to stop and answer things at this stage, and I may not answer any of them, in fact, because actually part of it is to decide on the next steps. We need to kind of understand what your queries are, really. then we'd also like to hear any experiences you have of supporting public health research. So if anybody at the end in the last 10-15 minutes would be willing to, you know, give a few nuggets of knowledge about how they've made it happen, that would be fantastic. So from about 1:45 to about 2 o'clock, we'll do a little bit of sharing of experiences if possible. So I will kick off. First of all, I just wanted to make clear to all, I'm sure all of you know this already, but I just want to make absolutely clear what public health is all about. It's not about dealing with individuals, it's about improving the health of the population as a whole. Now, obviously, some of the mechanisms by which you improve health are done on a one-to-one basis, but actually the things that really improve health are those things that are nothing to do with health services or social care services. They are to do with poverty, unemployment, the environment, our education, our access to food, the air quality, how we get about, and the nature of our society, the nature of our communities, and the people we interact with. And nobody knows the answer to how much of our health is, as a population, is due to health services, and I think it's probably quite conservative, the 10% that the Health Foundation have put here of the proportion of the population's health that's actually due to health services. But it's actually, you know, it's probably not far off that, realistically. We need to be very clear that health services have very little effect on the health of the population as a whole. That there is an exception for certain types of health services, and in particular, I would draw attention to perinatal care, for example, is something that we know is absolutely critical to the health of the population. If that's rubbish, the health of the population is rubbish, and I think that that's very, very clear. I mean, things like vaccinations are absolutely critical, but there are a lot of interventions that we do in the health service that have relatively little effect on the health of the population. You will get different estimates of that from depending on your perspective, of course. I've put Acheson's definition of public health here just because it's what everybody churns out, but it is quite a good definition. And the key thing is it's about society organising itself to improve health and prevent disease, rather than individuals doing things. Now, the reason I've categorized public health into 3 overlapping categories here. I haven't invented this. This is what public health people think they do. You know, this is what the Faculty of Public Health will say public health is. And so there's one group of activities which is about health protection, which is largely about communicable disease control. And I've put infectious because when I spoke to my husband, he said he thought communicable disease was a disease you talked about. And so you need to be very clear that, you know, it's about infectious diseases and environmental hazards. And so whether that's radiation, radon, air quality, that's the kind of thing we're talking about with health protection. Health improvement at and I've put in brackets at a population level because it's not about improving your individual health, it's about how we can, at a population level, improve the overall health of the population. And there are 3 main categories of activity in relation to that. One is actually measuring the health of the population, understanding the health of your population. You know, it's a big area of expertise there. The next bit is about how you design your system such that it can improve health. And the third, and drilling down a bit further at a more sort of micro level, it's about actually what interventions you put in place to do that, whether it's public health campaigns, information campaigns, or whether it's reducing sugar in drinks, in children's fizzy drinks and things. Not for children's fizzy drinks, just any fizzy drinks. Anyway, the third area of activity is what's called health service public health, and that is largely about how you influence the system to address needs equitably, to make sure that there is good use of public money in health services, and make sure that there is, you know, some justice in the allocation of resources to different bits of the health system. And I use the word system rather than service, because services tends to be about sort of hospitals and GPs and, you know, community services and things. I'm talking more broadly than that. But there are also a number of health service public health interventions which are public health people you know, are heavily involved in leading, and those there are lots of them, but these are the main ones. It's immunisations, vaccinations, you know, for example, the health visiting service. It's about prevention. It's not about treating people. It's not about identifying people with illnesses. It's about trying to prevent the effects of, you know, poor parenting on the children. It's trying to, you know, prevent ill health rather than treat it. Sexual health, obviously, you know, when somebody goes into an STD clinic, you know, they want to be treated for their gonorrhea or whatever, but actually a lot of sexual health activity, so to speak, is service activity, is about prevention. It's about preventing spread of STDs, for example. Also screening, which is the range of programs, as you know, are the preoccupation of public health people. Most public health people will put themselves in one or other category of these, largely, but they are overlapping. They can't be seen in isolation. I mean, for example, the health system strategy bit and health surveillance are bits which I feel I'm well equipped to deal with, and those are what I did mainly when I was working in the NHS. But just so you understand that that's how they will classify themselves largely. So how public health is done in England. Now, the key thing to recognise is that there's been a massive change about 7 years ago, really. And it took, as with any huge organisational change, it's taken years to embed. And I'm only really just feeling that it's embedded now. Health and Social Care Act changed the nature of public health activity completely. From 1974, the responsibility for improving the public health, for health surveillance, for communicable disease control, for health system strategy was with the NHS. It has now moved. The prime responsibility for the health population of an area is now the responsibility of local government. And that has been absolutely cataclysmic effect on the profession. And so it's gone from where it was largely in primary care trusts is where it's based. I mean, there were national bodies as well, but, and, you know, the Health Protection Agency, for example, which doesn't exist anymore. But it went into local government. It went into upper tier and unitary. I don't know how much you all know about the organisation of local government, but some parts of the country have got two tiers, upper tier and lower tier. Some parts are unitary. In other words, they do both upper tier and lower tier functions. But upper tier is largely where the responsibility to improve the health lies, though in fact lower tier local authority, local government activities also strongly influence health. For example, the men who pick up are mostly men, a bit sexist that, but the people who pick up our rubbish, I mean, that's a public health activity, you know, and that they are employed by the local, you know, the borough councils or rather than county councils, for example. And of course, environmental health officers now are all in lower tier local government, and they perform a public health function. Public Health England was formed, and that largely provides the national leadership on communicable diseases, environmental hazards, and health promotion. Though, in fact, the responsibility to deliver health promotion and to deliver local protection from communicable disease and environmental hazards is back down with the upper tier local authorities. It's not well, Public Health England and the local authorities will work together to deliver that function. There are also, obviously, there is a public health role still in the NHS. The people who deliver the vaccinations are employed by the NHS, as you know, that's mostly in general practice. You know, trusts have a role in tobacco control. There are all these things that the rest of the NHS does, and as I've mentioned, the lower tier local authorities. So directors of public health and their teams, and they have a team of variable size depending on the local authority. And also it's quite difficult to describe the size of their teams because it depends who you include in that team. But you will have a specialist, a group of specialists who will be a core group. There's possibly only, you know, 10 or 12 strong at an upper tier local authority. There are 130 directors of public health around the country-ish, changing daily, obviously. But this is what their role is described as: championing health across the whole of the authority's business, so that's everything. Promoting healthier lifestyles, scrutinising and challenging the NHS, and ensuring threats to health are addressed. So some of the things I've mentioned earlier, you can see under those categories. But of course, they also run the services that have been transferred from the NHS, many of which we might have called public health services with the NHS before. For example, health visiting, sexual health, tobacco control. So all the smoking cessation services, which is a small part of tobacco control, clearly, are now employed by local authorities, whereas they used to be employed by PCTs largely. They also have health protection responsibilities, by which I mean, you know, dealing with outbreaks of meningitis, dealing with outbreaks of diarrhea in nursing homes, and indeed a well-known virus that I don't need to remind you about. Now, the point of this change, which is so cataclysmic, was to try and return to the medical officer of health model that was there until 1974, which was, generally speaking, thought to be quite effective. I've read, you know, people disagreeing with that, but it was the idea that in local government is in a position to influence the factors that influence health. So, you know, whether it's transport, urban planning, housing, all the public amenities, you know, air quality, all those things, that local government is in a position to influence them in the way the NHS wasn't. The NHS did do that, and I've sat in many a council meeting as a public health physician working in the NHS, and I've given lots of advice on lots of things, on air quality management areas. I remember, you know, lots of things, but there was variable success because it was in a separate organisation. So that was the thinking. The second thing was, you know, the concern to address local concerns of priorities, whereas the NHS was more centrally run than local accountability was quite limited in the NHS, and also the advantages of democratic accountability in local government. Unfortunately, the reality was that there was a disruption of these systems, which were, although imperfect, had been developed particularly since 1974, to, you know, cover this incredibly complicated area. And the result was, of course, that many people retired early. Many people fled the NHS, fled the idea of becoming a civil servant. And there was, and it was very difficult for the profession at that time, because they all had to be 2P'd over to local government, and it was very difficult. And I think the biggest problem was that lots and lots of people just left. And so that's why, one of the reasons why I think now we've got to build up of enough people, and I think enough sort of momentum going again to make things a bit stronger. Of course, you know, I'm sure we're all Democrats, but there are downsides to democracy in the sense that you know, you've got to steer a path, and it's much more complicated than just saying these are the rules. And of course, you've got to deal with some elected members who may have, you know, unpalatable views about the public health that you have to deal with. But that's the reality. But it is a new challenge for public health. And this is a really key issue, that local government often doesn't understand its responsibilities. A well-known, very large council that I'm hoping to work with, or I've been trying to work with some time, has no mention of its responsibility to improve health on any of its leading, you know, its websites. Anywhere that I can find, even when I dug down, I couldn't find anything there. And this reminds me very much of working for when PCTs were formed. They didn't understand their public health role. I remember chuntering on about in board meetings for ages about, you know, you have a public health responsibility. You're not just a commissioning health service agency. They do have a less embedded research culture. As you know, the NHS has to do research. The NHS organisations have to acknowledge, you know, have to do research, have to support it. And there is infrastructure to support that. Also, budgets are much less protected. There is a ring-fenced public health budget, but of course, if it's small, it gets cut in the same way that other council services do, even if it is ring-fenced. Quickly about the specialist public health workforce and who they are. Directors of public health, I say 130 in the country, and consultants in public health, to be called that, they either need to be registered by General Medical or General Dental Council, or they need to be on the UK Public Health Register. And what that means is that after their degree, they've done 5 years after their degree, their first degree, they would have to have done 5 years of work, of which 2 have to be relevant to public health, and then they have to have done a further 5 years of full-time postgraduate training in public health. It's 3 years postgraduate for doctors and dentists, rather than that 5 years extra, but they all have to do the 5-year postgraduate training. There are other routes in called portfolio routes for people who've got significant experience, but largely speaking, you can assume they've all got that training. Those that aren't doctors or dentists come from a very wide range of professional backgrounds, which is extremely positive for public health, because it was rather medical before, frankly, and that's really positive. Now, the problem is that there are people called public health specialists in local authorities who don't have that, aren't consultants or directors of public health, aren't consultants, but they have a range of different sort of professional backgrounds and disciplines. So a public health practitioner doesn't really mean very much, because it can mean any number of things. Very highly qualified, less highly qualified, you know. So but most of them have a certain level of qualification to deliver their particular area of public health. So I think I'm probably telling you something you already know here, but as you know, the Public Health Research Programme has its challenges. The first is that it only focuses on interventions. The second is that those interventions have to be non-NHS. Many people in public health believe that to be not very helpful, because there's, you know, NHS, it's not, you can't separate things off that neatly. You know, that encourages silos. You know, it's not what we're about. The other thing is, as I've mentioned before, there are no funding mechanisms for supporting, for providing funds for support costs, excess treatment costs, which are what they're called in the NHS, or intervention costs. The NHS is the NIHR is trying to address these. It's a focus of much discussion in NIHR is how to promote research activity in local government, how to support local government to address some of those challenges. But from the point of view of local government, the problem is that they have no requirement to be a research organisation. Many of the public health specialist workforce have very limited research experience. They will have had to do a bit of research to get their postgraduate exams, but you know, it won't be the sort of research that most of us spend our time doing. elected members and local government officers, so you know, basically the politicians and the people paid to implement policy, don't necessarily value research culture, so they don't necessarily embed culture into their research into their decision making, and they don't support the organisation doing research. They're a much less stable work. I've put in the NHS and I meant in academia, but actually they do, but it's a very unstable workforce. I mean, the people are moving around all over the place, so you might be a different person you were working with. If you're implementing research, it takes 2 years, it might be a different person that you're dealing with. And local priorities are their main focus, which, as we know, is not particularly valued by NIHR research programs. Now, I'm not going to say any more there because we're running out of time. I was just going to say what some of my experiences, but we'll share this to kind of get the ball rolling about you thinking about it. I also wanted to put in these links here for you, which you probably know about already, but about the MRC Find program and NIHR Finder. It's Finder, not Finder, isn't it? It's not like Tinder. It's Finder. Finding researchers, finding researchers in the field that you could work with. So what I thought, we'd pause for a few minutes, have a look at your questions, and then if anybody's got any experiences of supporting a public health research program application you'd be willing to share, that would be really, really useful. Obviously, we've only got time for perhaps 2 or 3 people to talk about it. So perhaps if we take a few minutes break, we'll have a look at the chat, and I will mute myself, and then we will regroup. Thank you very much.
So we have some questions that have come from Wendy, and it might get everyone to think as well at the same time. So Wendy, I know, Wendy, would you like to ask your question about public health interventions, if that's okay to invite you to do that?
Yeah, I was just wondering how, particularly with public health research applications, how the interventions are usually funded. Every time I've helped advise on public health research funding stream applications, it's been a real problem sorting out the costing for the interventions. So I just wondered what the general, how they're generally funded.
That's a very good question, Wendy, and in fact, generally I don't know, but my personal experience is that there are two ones I've been involved with that I can think of this being resolved in. Usually it's not resolved, frankly, and nothing happens, the research doesn't happen. But in one of them, the CCG funded it. Now, it was a public health intervention, but the CCG funded it. In another, it was the local authority itself, the upper tier local authority, county council funded it. And I've learnt now, when somebody calls me up, you know, when I get an RDS, when I have to provide advice, is one of the first things I say is, you know, have you identified how this might be funded? Now, as it happens, when you say that and they kind of realise that, you know, the NIHR is not going to fund their actual intervention, they usually go away and say, oh, okay, I'll have to do a business case. And actually, you know, I mean, recently I found the money sort of seemed to come out of the woodwork, but they kind of have, sometimes they have this expectation that, you know, they're going to be able to get money for their intervention from the research programme. And as we know, that's not going to happen. I don't know if anybody else has any contributions to make on that.
Lindsay, I've just put a note in the chat to say that that's what Finder is for, is to link up researchers with interventions that have funding. So it's not always obviously necessarily relevant because there's a limit to what interventions are on there, but they're interventions that are generally funded by the voluntary sector or by local authorities or other means, and they are looking for a robust intervention to wrap around that. So they're often willing to link in with research teams if people are willing to sort of ad hoc go onto a team of a delivery that's already an intervention that's already been delivered. Sorry.
I think the other option is for researchers to be looking at pre-existing interventions, so that there's a programme that hasn't got an evidence base behind it, and the person is working in a local authority setting or even in PHE, but then they're starting to evaluate it like in a natural experiment or that sort of method.
Thank you. Lindsay, there are quite a few questions still, but shall we save some of those for the end if you want to proceed with the next part of your presentation?
Well, I think we could probably, realistically, we could probably take a couple more now, and then all I was going to do is really return to finish off. If anybody has any perspectives they'd like to share about the public health research programme decision-making process, that would be great. One of my colleagues in RDS Southeast, Rebecca, has offered to give a few perspectives because she went relatively recently to a programme funding meeting, and perhaps that would be a good thing to do in perhaps in 5 minutes. Should we have a few more questions? We could have a couple of other questions. Okay. Here we've got Dr. CRN, Anne-Marie.
No, there's one from Leston Williams. That was just before. Leston, are you there? And would you like to ask your question to Lindsay?
Yeah, sure. Sorry, my daughter's in the background. That's why I was on mute. So it's Leston Williams. I'm from the Health Services Management Centre at Birmingham University. And I'm really interested in the relationship between, even before COVID, I was interested in the relationship between the public health teams in local government and adult social care, because they obviously have overlapping interests and ideally would be working together. Do you know of any research or any insight into how they've been working together since the 2012 Act?
I think it's extremely variable around the country. I think there is an increasing recognition that they should be working closely together, but I believe, for example, from our local councils, that actually that's relatively limited. I mean, for example, we found that in Kent, for example, the social care department that is actually working quite hard to embed research you know, and has a sort of set up a number of systems. The public health people are trying to do research. They really, really want to, but they haven't really quite got the money from the council to do that yet, I don't think. And and it's a shame, because I think there are synergies there that, you know, they could, a lot of training, certainly in research terms, it could be done for both, really, couldn't it? My hunch is they're not working together particularly, but others may have other experiences, and I'd be very interested to hear that, actually.
Thank you.
And there's one more question. Anna Marie, is it all right to leave you until a little later point, but go to Andrew Bateman? And would you like to ask your question to Lindsay?
Oh, hi. It's not so much a question as or putting it out there about, you know, currently there's a call, well, there's three main calls that I'm aware of, but the one on homelessness sort of illustrates it for me, that sense of actually maybe some RDS proactive work we need to do about finding people who might even engage with the work to, I haven't fully interpreted what it means to say housing interventions for homeless and health, but I had that deep sense of wouldn't even know who, you know, which department to connect with in a university.
No, I agree, and I think that's really important. I mean, particularly because we know that the NIHR values research that is not just in one area. You know, and so actually we as researchers could help to make those links, couldn't we, to make them into bigger proposals. Of course, the problem is the funding isn't going to be the same in every area, because if it comes from a local authority, it's going to be you know, different levels of funding for interventions. But, you know, as you suggest, that there probably is a network of people working in these areas in local authorities across the country, but we don't know who they are. It's quite difficult to get in there, isn't it? So as you say, it's really, I think we could perform a function of bringing people together as well as in the RDS, because we can contact each other possibly more easily than local authorities can.
Okay. Right, so is there time for one more question, Lindsay, or would you like to?
I think so.
Okay, I think Anna Marie had a question, which I think is a really critical one. She said, does the CRN support public health research? It's a really interesting question.
Yes, and the short answer is no. But there is a slightly longer one. I mean, because I work for CRN as well, and I attend the national specialty group meetings for public health at the CRN, and we talk about this an awful lot. Now, the CRN does realise this is a problem. There's absolutely no doubt about that. The former CEO of CRN, who's just moved on, did come and speak to us as a group, the Public Health National Specialty Group, and said, I know this is a massive problem. In fact, I've suggested to them, you know, even that we change the name of the CRN, because the problem is it's not clinical research that we're supposed to be supporting here.
Yeah, I've just always just kind of wondered why they weren't supporting it, and also who can support it when you're trying to deliver the study.
I think one of the things is watch this space. I mean, it's a major preoccupation of NIHR at the moment, and the CRN, you know, the CRN specifically, because they recognise this is a massive problem. Yeah. And I think as long as we keep the pressure up, you know, on the NIHR, I think that something will change as a result. I hope. So watch this space. But at the moment, there is no support for it, basically.
Oh, real shame. Okay, thank you.
Yeah.
Right, Lindsay, do you want to move on to rounding up and do the next steps?
So the last couple of slides here. Rebecca. Oh, I'm not sharing my screen again, am I? Sorry.
No.
Sorry.
Just a few words about my panel.
Yes. Yes, it would be interesting to hear your perspectives on what the, you know, from the panel. Thank you.
So I observed the first day of a 2-day panel last October for public health research. And there were lots of very general things which apply to all the panels. They discussed the makeup of the teams and so on. So into the specific public health learning, they had a very strong interest in the use of logic models, and they wanted teams to be able to justify what they wanted to do in a very specific way. So the theoretical framework and the logic model was kind of stressed over and over again. And they were more open to qualitative research. So I'm a qualitative researcher, excuse me. And so I'm always on the lookout for that. But it didn't seem to matter what the methodology was exactly, as long as it was well justified and they could see the framework. They had also just been through the air quality call, and I think they'd had a lot of applications, all of which had been kicked back. And so they'd set up an event, which a lot of researchers came to, and they then got very specific guidance. And so this panel were overjoyed because a lot of those researchers had put in guided proposals based on this meeting, and they were putting them through. So they were really happy that they had all these positive outcomes and that people were kind of ticking their boxes. So I don't know kind of how that helped. One thing I did wonder was whether, based on that learning, they were going to then institute some more events around their calls and guiding researchers on that. So I don't know if that's something that they are going to do. What else? Yeah, I think in terms of kind of it being very specific public health learning, that is probably it, unless anybody's got any questions.
We are running out of time now anyway, aren't we? So I think what I was going to say for the next steps, thank you very much, Rebecca, that's really useful. Next steps, we will have a look at your questions and that if we haven't managed to answer them, and try, and I think it would be quite useful as a group of RDS people who are interested in public health, to carry on communicating with each other, because it isn't easy to support public health research. There are lots of challenges, as my previous slide said, and we'll share these slides so that you can go back and look for the bits I didn't go into great detail on. But it would be really useful to know what you think about further webinars that might be useful. I mean, maybe a session where several people share their experience of supporting fundable and funded bids. I've never supported a funded bid, but I have supported a couple of fundable ones, which was obviously important. Sorry, I've lost my screen. And the other thing is that I haven't alluded too much, but is engaging with the public for public health research grants is tricky, and also where they've had experiences of researchers managing to achieve organisational support, and that clearly means that the Director of Public Health has to be behind it, and if the Director of Public Health is behind it, is engaging with research, then the chances are you will achieve some organisational support. But you're not, if the Director of Public Health isn't interested, then that's unlikely to happen. But it would be really useful to know what you think. So please do send in your feedback, and that's my email address, and then the RDS South East General address, and I'd really like to carry on dealing with this issue. I think we need to try and find some solutions. Thank you.
Okay, well, thank you everyone. Please do get in touch. We will compile your questions, but we'll also, the next steps are to get some more feedback and potentially send out a questionnaire to see how we can organise the next session. Well, thank you very much everyone for joining us, and hopefully you have a good afternoon and try and enjoy a little bit of the sunshine that we've got left. Thank you. Bye-bye.
Bye-bye.